Hi, Dr. Reagan Robertson, CCO of Productive Dentist Academy here, and I have a question for you. Are you finding it hard to get your team aligned to your vision, but you know you deserve growth just like everybody else? That's why we've created the PDA Productivity Workshop. For nearly 20 years, PDA workshops have helped dentists just like you align their teams, get control of scheduling, and create productive practices that they love walking into every day. Just imagine how you will feel when you know your schedule is productive, your systems are humming, and your team is aligned to your vision. It's simple, but it's not necessarily easy. We can help. Visit productivedentist.com/workshop. That's productivedentist.com/workshop to secure your seats now.
You know, you have a patient that walks in and they have 6 millimeter deep pockets throughout the mouth. Have a lot of calculus and tartar, some stain built up. What is that person's risk factor? Are they high risk or are they low risk?
Hello, everyone. This is Dr. Bruce B. Baird, and you're listening to the Productive Dentist Podcast. In this podcast, I will give you everything that I've learned over the last 40 years in dentistry, working with thousands of dentists. I'll tell you, it's not that my way is the only way. It's just one that has worked extremely well for me, and I'd love to share that with you so you too can enjoy the choices and lifestyle that productivity allows. More time for things you love, increased pay, better team relationships, and lowered stress. Let's get into it with this week's episode of the Productive Dentist Podcast.
Hello, this is Dr. Bruce Baird, Productive Dentist Podcast. We're going to talk today about periodontal risk. You know, in our last podcast, we talked about risk factors in general and why I use them and why I think it's changed everything about the way I think about dentistry. It's literally changed my feelings about dentistry. When you're replacing things and you're taking responsibility for it and you're doing it for free, for not only is it costing you money, but it's really not your fault. It was the patient's fault. But yet I just didn't understand that. I always thought it had to do more with my margins than how much sugar they drank. And well, God had pretty good margins and they drank sugar and it failed. So, they didn't brush their teeth and they had periodontal disease. They didn't have it to start with. It came from somewhere. And so when I talk about periodontal risk, I always use, several different analogies. And I know John Coyce does a program on each one of these risk factors individually. And so this could be talked about for hours and hours. I want to give you my overview about periodontal risk and what am I thinking when what am I thinking about as I go through the patient? And I always go through these risk factors: periodontal risk first, decay risk, then functional risk, then aesthetic risk, then physiologic risk is one I added, and then psycho risk, which we'll talk about. So that we're going to be doing that over our next 6 podcasts. So periodontal risk, you have a patient that walks in and they have 6 millimeter deep pockets throughout the mouth. Have a lot of calculus and tartar, some stain built up. What is that person's risk factor? Are they high risk or are they low risk? Many times in the seminars I'll ask and people will say they're high risk. And my answer to that is, let's look at all the information before we make judgment on risk factors. What if this patient is 67 years old, has never been to the dentist in their entire life, and has these 6 millimeter deep pockets? Yes, they still have periodontal disease, no question. But how will they respond to that periodontal therapy and treatment? That's their risk assessment. It doesn't mean that they have it or don't have it. It's their risk for periodontal disease. The toughest patients I see are those ones that are 30 years old, 35, 39, 42, that are coming in every 3 months for recare, but are still having issues with periodontal risk. And I will tell you, there's a lot of things that we do in treating periodontal risk. Patients come walking in, and again, they say, I haven't been to the dentist in 5 or 6 years. Well, during this risk factor assessment, I'll say, we're starting to lose bone around your teeth, Mary. And what we're seeing, this is a bacterial infection. And not only that, this is an infection that can actually lead to a stroke or lead to a heart attack. We know that it's causative now because of the research that Brad Bale and Amy Doneen have done and some others. We know that it can be causative. So how do I handle that with patients? Well, first of all, they're either going to be a low risk. Patient comes in, they've got a little tartar, a little calculus. They've been going on 6 months. It's not about how often they've been coming in for recare. It's the damage associated with that. If you have a patient that comes in, hasn't been in 5 years, and has beautifully healthy gums and healthy teeth, what I tell the patient is, let's get you in. We know that the bacteria can play a role, but let's do this every 6 months. And we'll do irrigation. We use the laser on low settings. This is going to keep you healthy. The truth is that patient, I like to see them just in case we find something else going on in your mouth. And I'll tell the patient, truth is you haven't been coming in on a regular basis, but yet you're doing a great job. In my own mouth, my suggestion would be come in and get the irrigation and come get the laser pocket disinfection. Do that on a regular basis a couple times a year. You're never going to have problems, if you continue to do that. The moderate risk patient is the one who misses a few recares, is getting additional pocketing, is having issues, is not really committed to coming in and getting their teeth cleaned. They don't really understand what this can do. What we do know, and I tell patients, your gums are like a turtleneck sweater. They fit around the tooth. And it's very interesting. When you go in and probe, you've had patients, and you've been to the dentist before where they've said you have a 1 millimeter, 2 millimeter. They call out these numbers, 4, 5. What do those mean? Did they ever explain that to you? 99% of the time you say, no, not really. I just knew that the bigger the number, the worse it was. Yeah, well, here's what happens. It may take you, you're 51 years old now. It may take, when you were 28 or 25, you may have had pockets that were 2 and 3 millimeters deep. And it may take 25 years or 30 years for that pocket. The gums get puffy. Most of the time, it's the puffiness of the turtleneck sweater that starts to deepen the pocket, not the loss of bone. Until you get to where the number is 5. When it gets to be 4.5 to 5 millimeter deep, that's when I start waving a red flag. And why do we do that? Well, because the environment goes from what we call an aerobic environment where there's oxygen to a place where it's an anaerobic environment. You may or may not have ever heard those terms, but anaerobic, there's no air. So the bacteria that are living in your mouth under the turtleneck sweater, they start to change. And when it gets to be 5 millimeters deep, that's the stuff that starts to produce toxins that kill bone cells. And you start losing bone. And that's what we're seeing now. We've gotten to where it's 6 and 7, even some 8s and 9s or whatever. When it gets to 8s and 9s, I'm talking about the high-risk periodontal patient, in particular, if they've been coming in on a regular basis. So when these different types of bacteria, the facultative anaerobes, the spirochetes, I'm not talking to patients about this, but all of a sudden we start to see bone loss. We have got to treat this. We have got to get you back into good health because we know these bacteria in the 5, 6, 7, and 8s and 9s can cause a heart attack or a stroke. Patients go, oh my gosh, I've heard that. What can you do? I said, well, we have several things that we do. Our hygienists are experts. If they haven't been in a long time, it may be we're going to do what's called deep cleanings. I don't really go into scaling and root planings. I actually just call it our gum treatment program. In our gum treatment program, we use medication under the gums. We use the laser on pocket disinfection. This is the latest state-of-the-art stuff that you can have done anywhere. And what we want to do is we want to kill those bacteria. And it may take 4 or 5 visits for us to get that done, but then it's going to be a matter we want to keep you coming in. Maybe it's 3 times a year, maybe it's 4 times a year, but we'll help you determine what that time frame should be. It may get to a point where you're doing such a good job, we just need to see you a couple times a year. I don't fall to the old story of, oh yes, just because you have periodontal disease, you're going to have this done. I'm going to have to see you every 3 months. No. If you start following the recommendations and following the treatment that we're talking about, there's a great chance that you can get on another type of recall. But we've got to get your gums healthy. We've got to get you healthy because this is a reflection. We know that it affects the rest of your body. Does that make sense? And I always ask the patients, does that make sense? they'll say, well, no one else has ever really explained it to me that way. Yes. When can we get started? What about that patient that has the 8 mm deep pockets and they're, got stuff going on throughout the mouth? Well, in those patients, I've been doing Lanap surgery using the Perio. I love the Perio. I think it's an amazing tool. There's other companies out there that make lasers. I like the Fotona laser, the Lightwalker. I think it's I don't have one. I have their diodes. I have 3 of their diodes. I think they make amazing lasers. But I do know that the Perio laser is what I've been using, and I've been using it now for, 15, 16 years. When I first started using it, I think there were like 50 or 60 of them in the country. Today, there's probably 2,000 that are out there. When I started, there were no periodontists using it, except one, I think, maybe 2. Today, 8 out of 10 dentists that have gone through training now are periodontists. It took them a while, but they realized that laser periodontal therapy does work. Lanap, laser new attachment procedure, which is the term that the Millennium company has kind of trademarked. Lanap surgery, I know it works. I know that I can get patients to go from a 10 mm to 5 mm deep pockets or 4s by growing bone and by shrinking tissue. It's not apically repositioned flaps anymore. Maybe there are some indications for that, but I want the gums to stay. I want to grow new bone. Another interesting part about this is this risk factor of periodontal risk when I'm doing periodontal surgery and how it is associated with functional risk, or where patients are hitting too much. Does that have a relationship to the bone loss? And I'll tell you, it has an amazing relationship. I use a T-scan on every single periodontal patient that I do perio surgery on. I use a T-scan on. Never has made sense to me how the mesial pocket of 19 can have a deep pocket of 9 mm, and the distal pocket of 9, if it's a bacterial infection, has a 4. It seems like the bacteria wouldn't care whether it was mesial or distal. If the bacteria wanted to eat up stuff, they'd go all the way around the tooth. But it's not the way it is. It's not what we see clinically. But guess what I see clinically when I'm using the T-scan? Guess where they're hitting? Mesial buccal cusp of 19, way excessive. So we do an equilibration. I try to get their teeth where they're all hitting properly. I also recommend that periodontal patients have occlusal guards. So there's a big connection between the periodontal risk and other risk factors, as there are with every risk factor and the other risk factors. So there's some people that, have no periodontal problems. Great. There are some that have moderate problems. The moderate usually go into our 4 or 5 appointment gum treatment program. We get them using some type of a electric toothbrush. Some love the Sonicares. Some love the Oral-Bs. I just know that the electric toothbrushes, the automatic toothbrushes, do a better job of cleaning than just the manual brush. We all have patients who do everything. We all have patients that floss and brush and use water pick. I recommend all those things. But flossing, when you have deep pockets, maybe that's not the best thing to do. When you have deep pockets, just go around and take bacteria from one area and put it in other areas. The final thing that I'll talk about is DNA testing. We DNA test our patients to find out what kind of bacteria load we have. There's over 800 different bacteria in the mouth. And we know that there's 5 in the Baird treatment and kind of protocol that we've used is that there's 5 really pathogenic bacteria, and they're the ones that cause most of the overall health problems that we end up with: increased risk of stroke, increased diabetes, increased risk of heart attack. So there's a lot of studies on that. And so what we do, we do DNA testing. And so we test for oral pathogens. We did it on myself. And this is when the research first came in from Baird. We did the research. They did the research, and I read it, and I was like, oh my gosh, I've had a little bit of heart problems. I've had some issues. I've had some periodontal pocketing. I want to know what kind of bacteria I have. So We did the testing, found out, oh my goodness, not only did I have one of the 5 bad pathogens, I had all 5. What did I do myself? I went through and had Lanap surgery. I had my partner do Lanap surgery. Why? Because I believe in what they're talking about. I also went through and used medications. We use antibiotic therapy with the gums. That we're going to do an entire podcast just on that method of treatment in the future. So hopefully this has been beneficial to you. Hopefully you see why we have to look at this foundation issue. We knew that in dental school. Always look at the gums first. Always look at the foundation first. I tell patients, it's kind of like me being a builder. I always want to make sure if we're going to build something, it's on a great foundation. Once you have that great foundation, then you can move to the next step, which might be restorative type things with decay or erosion, those kind of things. And I'll talk about kind of how we talk to the patient about that in future episodes. But remember, the gums are like a turtleneck sweater. It may take 20 years for it to go from a 3 to a 5, but to go to a 5 to a 10, it might take 5 years. It may take 3 years because the bacteria have become really bad bugs, and it's time to do something. So look forward to our next episode together. Luck's not by chance.
Thank you for joining me for this episode of the Productive Dentist Podcast. If you found this episode helpful, make sure you subscribe. Pass it along to a friend. Give us a like on iTunes and Spotify, or drop me an email at podcast@productivedentist.com. Don't forget to check out other podcasts from the Productive Dentist Academy at productivedentistpodcast.com. Join me again next week for another episode of the Productive Dentist Podcast.